I'll now introduce you to our facilitator today. We have Kara Murgatroyd, and she is the education team lead. So take it away, Kara.
Thanks so much, Marco. Welcome everyone this afternoon, and we thank you for joining us this afternoon. Our topic is hearing loss and reducing the risk of dementia. And in a few minutes, I'll actually be introducing you to our guest speaker. But first, we'd like to acknowledge that we are gathered today on sacred land that has been the site of human activity since time immemorial. We are in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq Nation, the past, present, and future caretakers of this land. I want to also recognize and offer gratitude to African Nova Scotians and their ancestors, whose histories, legacies, and contributions in 50 communities for over 400 years have enhanced the part of Mi'kma'ki colonially referred to as Nova Scotia. In the next slide, you'll see that at ASNS, we're working toward becoming a more diverse and inclusive organization where all Nova Scotians truly see themselves in the organization. We use the acronym IDEA, which actually stands for the acronym Inclusion, Diversity, Equity, and Accessibility. So it's really looking at applying a person-centered lens to all of the work that we do and ensuring that we're fostering a sense of belonging in all that we do. And so to facilitate this work, we're grateful to some of the collaborators that you see there on the screen. So thank you again for joining us. And our audience today includes people living with dementia, people caring for someone with dementia, and then there are other individuals who would like to learn more about dementia. So today we'll have about a 30 to 40 minute presentation followed by Q&A. And so today's presentation again is hearing loss and reducing the risk of dementia. So it's my pleasure today to introduce to you Dekota Clayton. And Dekota is an audiologist and co-owner of Hear Right Canada, Nova Scotia Incorporated. He earned his Master of Science in Audiology from Dalhousie University. Dekota is a very passionate clinician who strives to do his best and go above and beyond to ensure that his clients are living their best quality of life. Dekota holds his full license in audiology with the Nova Scotia College of Audiologists and Speech Language Pathologists. That's a lot to get out there all at once, Dekota. So Dekota is born and raised in Halifax, and he's very proud to be practicing at home where he can give back to his community. So welcome, Dekota. I'll hand it over to you.
Well, thank you, Kara. Welcome, everybody. So it's my pleasure to give this talk today on hearing loss and reducing the risk of dementia. So I couldn't have said it any better than Kara. You know, here's a little bit of background on myself. So, you know, I did 2 degrees at Dalhousie, one in 2010 and one in 2013, double major in psychology and sociology. And then I did my master's in audiology where I graduated in 2013. And after graduating, I became the territory manager and audiologist for Atlantic Canada. So I would travel around Atlantic Canada, do presentations similar to this, meet with different businesses and different health professionals and look at improving healthcare for many different clinics in Atlantic Canada. As Kara mentioned, you know, I've been a registered audiologist since 2019 with the Nova Scotia College for Audiology and Speech Language Pathology. This college only became available in 2019. So it's a fairly new college, but we're making great strides. And then last year in January, I became, you know, the co-owner of Hear Right Canada. So I'm happy to be here and thank you guys for taking some time out of your day to learn more about this exciting topic. So before I get into the actual presentation, I'd just like to acknowledge the references where most of the content has come from. So there's been 2 publications from the Lancet Commission, one in 2017 and 2020. And the Lancet Commission is focused on prevention, intervention, and care. Okay, and they focus on prevention and delay of the onset. Okay, so they quote that dementia is by no means an inevitable consequence. So what can we do to kind of slow down the risk or reduce the risk. We'll get into that in quite a bit of detail here shortly. And then I'm also going to highlight a few slides from the landmark study, which is done by the Alzheimer's Society just this year, which is a micro simulation study to look at and project the number of people who will develop dementia over the next 30 years. When I think of this micro simulation study, I think of it as like building a city and seeing how the city interacts with all the different people and things in the city, and then look at what the outcome is. I think it's a pretty cool concept. So I'll go through that a bit as well. All right. So in looking at, cognitive decline and dementia, okay, these may or may not be words that most of you are familiar with. And cognition is very complex, but, to simplify it a bit, we can think of cognition as our thinking ability. And this includes our language, memory, problem solving, navigation, processing sound, speech, our vision, very complex. And then we have, cognitive decline or mild cognitive impairment. This is, slight but noticeable changes in our thinking abilities that's measurable, okay? And this also can include our memory and thinking skills. And we know that individuals with mild cognitive impairment are a higher risk for dementia, okay? So dementia, okay, so the Alzheimer's Society does a fantastic job providing resources, for Nova Scotians as well as others in terms of having access to resources and providing information to help individuals along the way of this journey. And dementia is very complex, and it can impact many areas of an individual's life. We know that dementia is a result of symptoms related to disorders of the brain that can cause short-term and long-term memory loss. Often people have difficulty with language, problem solving, thinking, spatial awareness. It can affect mood and behavior, okay? And we know that dementia affects everyday activities. So the things that we're used to doing on a daily basis, we're now having challenges with this, or they often require help from other individuals. We know that 66% of dementia cases are Alzheimer's, which makes it the most common form. And some other common forms are, vascular dementia, frontal lobe, as well as brain injury. And personally, this hits me quite hard personally because, my mom, she has very severe dementia and she has hearing loss. So when I think about the impact and the challenges that I have on a daily basis, providing care and, trying to take care of my mom or helping my sister who manages the care, every day is different because we don't know what type of day my mom is having. So we do our best to support her and include her in all the daily activities. But personally, hearing loss and dementia, those two together are like a double-edged sword. So now let's take a look at some Canadian statistics for hearing loss and dementia. So we know that 1 in 4 Canadians report having some degree of hearing loss. And we know that aging or presbycusis, which is age-related hearing loss, is the #1 cause of hearing loss, okay? So as a natural part of aging, the little hair cells in our ear will die off, and that can result in a high-frequency hearing loss. Looking at some of the dementia statistics, in 2020, there were almost 600,000 persons in Canada living with dementia. And looking at some of the projections, we know that this number may triple by 2050 to, almost 2 million individuals. Most of the care is done by care providers, and these are family, neighbors, or friends. And as I mentioned personally, I know that my sister, who's the primary caregiver for my mom, she spends a lot of hours taking care of my mom and making sure that, she's getting everything she needs on a daily basis. And, the future outlook for dementia in Canada is pretty scary. And some researchers are saying that this is the greatest health challenge of Canada's aging society. And we know that we already have challenges with the current healthcare system. Okay, so how can we get ahead of this snowball and slow things down? Okay, so I'm going to talk a little bit about that for the rest of the presentation. So according to the Lancet 2020, 60% of dementia is non-modifiable. This means we cannot change the outcome. You know, for example, age, genetics, these are things that we can't change. But interestingly, they found that 40% of dementia can be modifiable. And they identified 12 risk factors throughout the life cycle that we can modify, change, or potentially stop doing that can increase the risk that we do not get dementia, okay? And if we treat the risk factor, we can delay the disease or condition. And this goes into what the landmark study talks about and how we can slow down that age of diagnosis and what it can mean for Canada in terms of the number of people living with dementia. So here's a little snippet from the Lancet 2020 and the risk factors that cannot be changed, as I previously mentioned. Age, sex, genetics. I won't really be focusing on those, but I'm going to focus extensively on the risk factors that can be changed or modified. And they're broken down in 3 stages: early life, up to age 45, midlife, age 45 to 65, or later life, age 65 and older. And what the Lancet Commission did, they assigned a percentage in terms of reduction in dementia prevalence if this risk factor is eliminated. So you'll see in future slides a number and then the life cycle, and that number would be if we kind of reduced and eliminated that risk factor and what it could do to slow down dementia. All right. So number 1%, alcohol, midlife, okay? And they say that we should, be reducing to 21 units per week. Now a unit is arbitrary, but here I have a unit as 10 mils, okay? They defined heavy drinking as 21 units a week, which is almost like 2 bottles per se, 2 bottles of wine. And we know that heavy drinking is associated with cognitive decline, dementia, and brain changes, and it can lead to an earlier onset of dementia. When we think of how does alcohol impact the brain, well, we know that we see right side hippocampus atrophy. So the hippocampus becomes smaller, and the hippocampus is the part of the brain on the right side that's involved in spatial memory. So spatial memory and awareness, okay? And, speaking from personal experience, I was a student once. We would like to have a good time sometimes, but the next day you meet up with your friends and you say, hey, what an awesome time yesterday. But what happened? Okay, so alcohol can have that memory inhibition where we just don't remember parts of the day or parts of the night. So, reducing alcohol intake midlife is a preventative factor. Obesity, 1% midlife, okay? And obesity is measured by your body mass index or BMI. And it's a pretty simple calculation. So to get your own BMI, if you wanted to do this, you could take your weight in kilograms. So divide your weight in pounds by 2.2. Divide that then by your height in meters squared. And then we get a number. And then you can see there's different categories for normal, overweight, obese. And a body mass index greater than 30 is associated with late life dementia. Okay, but we know that weight loss of just 2 kilograms for people with a BMI greater than 25, it can improve our attention and memory. But, the research is still ongoing in this area because the long-term effects is still unknown, okay? So diabetes. diabetes is very common, especially in a lot of the clients that I see. A lot of diabetes, and we know diabetes affects, 3 parts of the body. I mean, more than that, but 3 are the eyes, the ears, and our feet, okay? And the risk of dementia with type 2 diabetes increases with duration and severity. So the longer you've had type 2 diabetes, the greater your risk. And at this point, the research is unsure if diabetes medication reduces the risk of dementia, okay? Because there's a little bit of research, it's not recognized as a health condition yet, but there's a thing out there that some people are calling type 3 diabetes, which is a term some people use to describe like Alzheimer's disease. And some scientists propose that, they propose this term because they believe that insulin dysregulation in the brain causes dementia. But as I mentioned, this is just an early investigation, but this might not be something that you guys have not heard before. So diabetes, we got to manage it. We got to keep our blood sugars under control, especially later in life, okay? And I know that if you're a diabetic, your risk of hearing loss is 2 times greater than somebody who's not a diabetic, okay? So there's a correlation there as well. Air pollution, 2% later life, okay? Now we can expose humans to a bunch of air pollution and see what the results are, and that's just unethical. But in some animal models, we know that pollutants accelerate, there's neurodegeneration in your cerebral vascular system, as well as it can inhibit like cardiovascular disease. So we all love the smell of a good wood burning fire, but there's fine little particulate matter that's being released. And, intaking and inhaling a lot of these chemicals has been identified as a risk factor, which can increase our risk for dementia. So, it may smell good, that nice burning fire, but it could be causing some permanent changes in our brain. And at this point, there's little data on industrial pollution, okay? So industrial pollution is, the big carbon footprint, and there's, certain centers in Canada whereby you have a large output of carbon monoxide and other chemicals. And I think, we're all working towards a greener world, a greener economy. And I think that'll be beneficial for everybody. Cleaner air is better air. So next, I'm going to talk about reducing hypertension. Okay, so maintaining normal blood pressure is very important for our overall health. Normal blood pressure is 120/80, okay? And we need to maintain systolic, so the top number, which is the maximum pressure the heart exerts while beating, of less than 130, okay? The diastolic, which is the bottom number, is the amount of pressure in the arteries between the beats. And we know that treatment for hypertension or treatment for high blood pressure is the only known effective medication to prevent vascular dementia. So if you have high blood pressure, it's important that you maintain and keep taking your medication as per your family doctor. Physical activity. So, staying active is good overall. Breaking a sweat, very important, okay? So physical activity, 2% later life. I'd say physical activity is important all throughout your life, but if you can do it, later in life, even better. So the research is showing that there's an increased dementia when physically inactive for 10 years prior to the diagnosis, okay? I see it a lot in my practice that a lot of us become sedentary as we age. We may not be into doing the things that we love to do. We may want to watch more TV, but if we're not using the muscles, we're losing those muscles too. So with less physical activity, you have an increased risk of falling. And we know that falls are related to, hearing as well. Okay, so there's an interconnected system there. there's limited data on the types of exercise. And I would say that the important thing here is breaking a sweat several times a week. So if you're going for those walks, get the heart rate up, break a little sweat. And that's what's shown to be protective when it comes to, reducing our risk. And we know that regular physical exercise has beneficial effects for our diabetes, our weight overall. It can affect our mood, and as well as, keep the heart blood flowing and good for our cardiovascular health, okay? So I'd like to share a little story here, and this is about a client. So I had a client, 93 years old, who I saw in one of the locations, and I was doing the case history, not on many medications, very healthy overall. And I asked her, what's the secret? And the simple answer was, I walk every day. I try to walk for 30 minutes a day. And I'm like, that's it? This person at 93 years of age just went for a full knee replacement. So to me, age is one thing, but being healthy at an older age is also very important. So being physically active, I believe for her is what's allowed her to have this knee surgery at such a later age. So traumatic brain injury. So this one's pretty scary, okay? So hits to the head, 3% midlife. And if we think of traumatic brain injuries, they can be mild in the form of a concussion, or they can be severe in terms of like a skull fracture, a bleed, an injury from a car accident, military, recreational sports. In football and some of these physical sports, concussions are fairly high. Hockey as well. I know like Sidney Crosby has had several concussions. So dementia after having a traumatic brain injury, the risk is the highest within 6 months post-injury. And this risk remains long-term. Just by having a simple concussion, it doubles our risk. And if you think about the military, increase with risk with greater severity of injury. When we think of traumatic brain injuries and something as simple as a concussion, not a severe brain bleed, but we know that concussions can cause sensitivity to loud sounds. So I often see clients in the office, they may or may not be wearing hearing devices, but if they are, they come in and they have this like fog whereby I have a heightened sensitivity that I never had to loud sounds. And right now there's a lot of ongoing research regarding, football players and following them through their careers to see how concussions impact the structures of the brain over time, okay? So concussions and hearing loss, definitely something to keep on the radar. Social engagement, this is a big one. You can see 4% later life, okay? So social engagement is a protective factor and it enhances our cognitive reserve. This is like that cognition, okay? Frequent social contact at the age of 60 reduces the risk of dementia for 15 years, okay? So keeping connected with your friends and family and loved ones and staying engaged, even in times of the pandemic, whether it's through virtual, just keeping that communication and staying engaged, this is a protective factor across cultures and sexes. On the flip side, if we look at social isolation, this increases the risk. And we know that social isolation is also the consequence of untreated hearing loss, which I'll talk on in a bit. So social engagement, you can see, has a 4% risk to reduce the risk of dementia later in life. So depression, 4% again, later life. So there's evidence that suggests depression may precede other dementia symptoms, okay? It's a very complex relationship. And I often see individuals in the clinic that have that social isolation, the anxiety, maybe they're borderline depression, but it could be resulting from their hearing loss. Treated versus untreated depression is not well investigated, and we don't really know how antidepressants kind of impact this risk. We do know that the depressive episodes increase the risk. Okay, so depression, I would say, is a very complex situation. But if you know someone or think that somebody is depressed, I'd say getting them in for a baseline hearing test would be a good starting point as well, because perhaps they're kind of going down the vicious cycle of untreated hearing loss, which depression is a consequence of that as well. So smoking, I didn't put up one of those nasty images, but I know like Health Canada sometimes puts those nasty images on some packaging to deter people from smoking, which I think is not a bad thing. But smoking has a 5% in a midlife. So we know that smokers are at a higher risk of dementia than non-smokers. But the good news is even stopping at an older age reduces the risk. So it's never too late to quit smoking. And we often hear a lot about secondhand smoke, but there's not a lot of literature on secondhand smoke and what the risk, for dementia is or how this impacts changes in the brain. There's just not enough literature out there yet, but there's ongoing research in this area as well to try to further investigate this complex relationship. So education, less education, 7% early life. So this is before the age of 45. And if you think of it in pretty simple terms, education from primary to teenage years is the most protective. This is when our brain has the greatest plasticity, the ability to retain and learn new information. It's never too late to learn a language, but people often can learn a language at a younger age much faster, okay? So more education, we have more cognitive reserve, so more connections and networks within the brain to keep things strong. And lifelong learning is beneficial, okay? So keep doing those puzzles, the Wordle, Sudoku, staying engaged. We know that 65-plus-year-olds who read and play games show a reduced risk of incidents. And personally, my mom loves watching the Game Show Network. She always wants to see what's on there, whether it's Family Feud or, I don't know, Pass the Cards or some of these new shows. She loves watching and learning about new shows. So we try to stimulate her as much as possible. All right. So now we're at the big one. Okay, 8%. Hearing loss has been identified as the #1 modifiable risk factor midlife to reduce the risk of dementia. So maintaining good hearing health is very important, okay? As you can see on this little graph here, normal hearing, there's a bit of risk, I would say, which is likely due to aging. But as we have a mild hearing loss, a moderate hearing loss, and then a severe hearing loss, the risk of dementia increases exponentially. So more hearing loss, greater the risk, okay? And we also know that an untreated midlife hearing loss causes a reduction in brain volume in our temporal lobe, entorhinal cortex, as well as hippocampus. There's the hippocampus again, okay? So our temporal lobe is responsible for auditory information and memory, okay? Kind of sits on the side here. Our entorhinal cortex, it's a hub for memory, spatial navigation, and our perception of time, okay? And then the hippocampus is there again, the hippocampus memory, okay? So untreated hearing loss not only affects our day-to-day ability to communicate, but it impacts our quality of life, our memory, as well as increases our risk for dementia. So I already talked on this a little bit earlier. So here's the list of some of the common symptoms of untreated hearing loss. We know that hearing loss causes a strain for us to hear. We see it all the time. People come in, they're just tired. I've been straining all day to hear. So our cognitive reserve is used up, okay? Untreated hearing loss can really lead to social isolation. Mr. Jones loved to go play cards every Tuesday night, but now Mr. Jones doesn't want to go anymore. He's not hearing well, so he's disengaging himself from stuff that he loved to do. It can also lead to loneliness. Again, If I'm used to playing bridge every Friday night, but now going to bridge is frustrating and I'm not enjoying it, I'd rather just stay at home. Loneliness can lead to depression, and we think of depression with less cognitive stimulation. And in the clinic here, I often see clients who are very anxious, or they're starting to get into that social isolation piece, the loneliness. I've had clients that have sang in a band for 20 years. Now they have a hearing loss. They can no longer enjoy the music or enjoy the sound quality. So what do? They decide not to go. But I can tell you personally, when we fit them with hearing aids and we change their life and improve the quality, these clients go back to doing what they love to do. So that's the important aspect. It's never too late to get back to doing what we love to do. Looking at hearing loss, we know that the research shows if you have a midlife hearing loss, hearing aids are found to be protective. So people with treated hearing loss have the same risk as somebody with normal hearing. So this is a pretty big finding. We know that hearing aids improve your listening effort. They make it easier for you to hear and understand. They preserve this cognitive reserve and they help keep us engaged. Okay. So now let's switch gears a little bit and let's look at the landmark study, which just came out this year. And as I previously mentioned, this was a microsimulation study to project the number of people who will develop dementia in Canada over the next 30 years. And they used publicly available data from Stats Canada to create these agents. And agents are associated with different characteristics such as age, sex, and health status. And then they looked at, as I mentioned, the model simulates these agents and how they interact over time. And this gives us an understanding of what would happen if we could delay the age at which dementia began by 1 year, 5 years, or 10 years, okay? And I must say here, this is taken from the landmark study, table 7 here. You can see, as you would expect, any delay is better than no delay, because you can see 1 year, this is how many fewer cases. And with Alzheimer's disease being the most common, you can see there's a greater reduction in Alzheimer's. But overall, you're looking at almost 500,000 less cases of dementia. 5 years, you're looking at, almost 2.3 million fewer cases. And then 10 years, over 4 million fewer cases of dementia. So we talked a little bit about what are some of the things we can do to prevent and hopefully delay the risk, okay? And looking at if we can delay this risk, look at what the positive impact would be on our healthcare system, quality of life for these individuals, as well as, less of a burden on society and the caregivers, to take care of our dementia clients. So pretty powerful numbers here, okay? So I've just reviewed what some of the modifiable risk factors are. We can see if we can delay it by, even 1 year to 10 years, we do see a positive impact in terms of less dementia cases. And I'm going to end with this slide here, okay? And it's a challenge for anybody that wants to take the risk. And if you have concerns, get your hearing tested. We know that aging or presbycusis, this is the #1 cause of hearing loss, but we know that aging is also one of those non-modifiable risk factors for dementia. If we don't get ahead of the curve, we know by 2050, there's going to be, around 1.7 million people living with dementia. These 12 modifiable risk factors were identified to reduce the risk, with hearing loss being the #1 modifiable midlife risk factor. Okay, so if you have a hearing loss in your 40s, 50s, or 60s, get ahead of that curve. Okay, And we know that using hearing aids was found to be protective. Okay, so the research says, and we know if you don't use it, you lose it. So let's be proactive with our hearing health so that we can live a better quality of life for a longer time. And I'm going to throw it back to Karen now.
That's awesome. Thanks so much, Dekota. A really important presentation, the information that you shared. You know, I don't think for a number of us, you really highlighted the impact that having a difficult, like having an impairment in hearing can really affect our social connections and really our quality of life, because we're social beings and wanting to be with others. And if we start having a difficult time in following along with a conversation, we may become self-conscious that we can no longer do that. And so, of course, yeah, you're going to have that withdrawal. And when along with the withdrawal comes the loneliness. And I'm thinking, especially, just coming out of, and we're kind of going back into with the fall and more numbers with different viruses that are keeping us at home, just to be very aware of how important it is to have an assessment to see whether or not, those changes are contributed or caused by hearing loss as opposed to something else that we might automatically jump to, as far as a conclusion is concerned. So I do have some questions, Dekota, so I hope you'll stick around, I know.
Oh yeah, I'll stick around for sure, absolutely.
to answer some of those questions. And I guess one of the questions here is, does a person need a referral to a doctor to have their hearing tested?
That's a really good question, and it's one that I see here in the clinic all the time, or my receptionist, whereby they call and they're like, how do I get in to see you? Well, there's no referral needed to book a hearing test with an audiologist. So you don't need to go back to your doctor or get your doctor to write a prescription. It's simple. You can pick up the phone, call any hearing clinic, whether it's a private clinic or a public clinic, which is Nova Scotia Hearing and Speech. Nova Scotia Hearing and Speech, it's covered by MSI. You may wait a little bit longer, but it's a complimentary hearing test. But most people don't know there's no referral needed. And typically in private practices, hearing tests are often complimentary as well. Okay, so even in my practice, we don't charge for a hearing test unless we had to do a report to your doctor or an ENT. But to pick up the phone and call, no referrals required. So that's a good one. We get that all the time.
Excellent. And I think, it's important for people to know that for that memory test, I'm going to my background and working and supporting people with dementia memory test, but for the hearing test specifically, the MSI would cover it in some instances. And then with some clinics as well, they would cover that that first initial cost for the hearing assessment.
Absolutely. Yeah.
Yeah. Okay.
Yeah.
Another question here that I have in the chat is tinnitus considered to be hearing loss?
So tinnitus is typically a symptom that something is wrong in your auditory system. Now, I would say that tinnitus and hearing loss go hand in hand. The number one reason for tinnitus is hearing loss caused by noise exposure. But we know that tinnitus, I would say if you have tinnitus, get into a hearing clinic for a tinnitus assessment where they can, they'll test your hearing, but we'll also look at what pitch or how is this tinnitus impacting your quality of life. Tinnitus is a bit different than hearing loss, whereby people are hearing a constant ring in their ear all the time. I'd say 80% of my clients have tinnitus. And we know that, tinnitus is just that symptom that something is wrong. But is it hearing loss? Is it a result of medications? What's kind of causing it? Tinnitus is affected by stress, sleep, anxiety, and you kind of get into a little bit of a hamster wheel. So I actually did an article for the Trident on tinnitus and talking about what are 5 things that we should know about tinnitus. So I'd say if you suspect you have tinnitus, again, start with a hearing test to rule out that, hey, my hearing is okay. But if it is tinnitus, what else can I do to manage it?
Okay, and actually a follow-up to that is, how would you treat tinnitus or tinnitus?
Yeah, so Tinnitus is like that phantom perception of sound, right? So the only person that hears it is the person that's living with it. And oftentimes people hear their tinnitus stimulation or the tinnitus sound in their ear the most when things are quiet. So when they get ready to go to bed at night, it's like, oh, who turned my tinnitus up? Nobody really turned it up. But if you think of it as, here's my tinnitus and here's the background noise. Throughout the day, the background noise is kind of covering it up. But as I go to bed, whoa, the background noise is gone and it seems sky high. So there's different ways to treat tinnitus, counseling and sound therapy. So we use sound to enrich the auditory system again, because it's not getting proper stimulation. So we typically treat it with a customizable sound, counseling, sound therapy, or like a combination of tinnitus retraining, whereby we're trying to retrain your brain to reduce your reaction to it. Because tinnitus isn't the problem. You have a stressful emotional reaction to it, which then causes us to become stressed. Well, what does stress do? Increase our perception. Stress affects our sleep. So we got to just break that cycle and work on changing the way the limbic system reacts to the tinnitus perception. So
Great. Excellent. Thank you. There were a few questions specific to tinnitus. So I think you covered all the bases there.
Yeah.
So when we're thinking about, a lot of the risk factors that you discussed today, Dekota, we're really looking at that midlife range between 45 to 65 years of age. So I'm thinking for those of us in that range, and even for those of us either below or above that range, what do we do? What can we do to maintain good hearing health?
So to maintain good hearing health, I think it starts by booking a baseline hearing assessment. We all feel that we can hear very well, but we don't know because it goes so gradually. Okay, so hearing loss is often gradual with age. We just lose a little bit over time, and then all of a sudden, yeah, I'm not understanding you very well. But I'd say, we go get our eyes tested every 2 years. You go, whatever, you get your mammogram, you get your prostate checked. They're part of just maintaining general health. If we can be proactive and book a hearing test, having that baseline is that picture in time. Because a question I get is, I have a hearing loss now, but what was it like 10 years ago? That's a good question, because I have no record of it. So as an audiologist, I can't do a comparison today of what your hearing was like 5 years ago if there's no record of it. So if your hearing is great, well, we'll see you if you're having issues, but at least we have that picture. So I'd say get a baseline hearing test regardless of your age.
Okay, excellent. And I'm just thinking, even for myself, I'm trying to remember when the last time was that I actually had a hearing test, so that I could have that baseline.
Mm-hmm.
Got another question here. So I have some hearing loss, high frequency. I get my hearing tested every 2 years, and I've been told I don't need a hearing aid yet. Is there a consensus on what level of hearing loss should be reached before a hearing aid should be worn?
So it really depends on, of course, the test shows that this person just has a mild high frequency hearing loss. So it's not, we won't say that it's very bad at this time, but it comes down to, we have clients that have mild hearing loss in the higher pitches, but it's impacting their quality of life so much that they want to do something about it. So it's very variable. Some people have a mild hearing loss in the higher pitches. It's not bothersome yet, and they're doing okay and they can get by. But other individuals that are, maybe still in the workforce or have a demanding job, that difference in clarity for them, the higher pitches affect clarity. So we hear people, but we just don't understand them. I would say that, the clinician will make a recommendation, but if you feel that it's impacting your quality of life and you're starting to restrict on the stuff that you love to do, whether the paper says it or not, there's a phenomenon of like hidden hearing loss. Some people measure normal hearing on an audiogram, but they get in a crowd and they can't process speech. These people may benefit from a hearing aid even with normal hearing in that environment. So it's very variable. But I would say, if it's impacting your quality of life and you're noticing, I'm just not doing very well, I would say do a trial. All clinics offer a trial period where you get to try hearing aids. we offer a 90-day trial period. And if you're not satisfied with them within 90 days, you return them. So you could take them for a test drive and see if you get benefit. And if you're not getting the benefit, then don't invest the money at this time.
Yeah, and I guess that would lead into a question too, as far as the cost associated, Dekota, with some of the hearing devices. I know we spoke to this just prior to opening up the conversation today, and so there were a couple of ideas that you had brought up in our conversation as far as cost.
Yeah, so cost of a hearing aid is one aspect, but you got to look at the service behind it, right? So an analogy I like to give, you could have $1 million Lamborghini, but if you can't take it to get the oil change or get it serviced, it's going to die on you. Okay, and a hearing aid's a medical device, and the price really depends on your lifestyle. Okay, so hearing aids can range in price and go all the way up, just like anything that we buy. But there's many different programs out there. Some of them, government funded, whereby if you're still working, you might qualify for, some help from the government. There's also programs such as workers' compensation or Veterans Affairs if you've been in the military, or you have occupational noise-induced hearing loss, whereby if it's caused by your job, perhaps you can apply for that. But the cost of a hearing aid is one aspect, because in Canada, we know that about 25% of people who need hearing aids get them. But there's other studies in other countries whereby they give hearing aids away for free, but the adoption rate is the same as Canada. And I think it comes down to there's still so much stigma around these old, big hearing aids, when in fact, that's not the reality anymore. Hearing aids don't whistle. They're very cool. They connect to your phone. We could be streaming this Zoom meeting through my hearing aids automatically. Like, the technology is there, but I still think there's a stigma when it comes to wearing a device, and then my vanity. The price is something that can be, you can get hearing aids that range in price, and even ones that are really cheap. Being in something that is, being in a hearing aid is better than not having one, period.
Right.
Right. So I'd say, money aside, having the device, as I presented on, is going to be long-term beneficial, not just to reduce the risk of dementia, but keep you connected, keeping you engaged, keeping you in the workforce, letting you hear your grandkids. All of that stuff together is hearing.
Yeah, and let's get back. I have one more question, but getting back to that, staying connected, getting you, engaged with your family, with your community, being able to be part of those conversations. I want to get back to there, but I do have one question, which is related to research. So you may have the answer to this, Dekota, maybe not. And if we don't have the answer, we can find maybe some information later. You can direct your question to the info line. But this question, is there any research into an individual's financial status and how it affects hearing loss and dementia?
Oh, absolutely. I could share a slide on that, not regarding the dementia, but we know that hearing loss is tied to your economic and financial status, 100%. So when untreated hearing loss, I could pull up a slide pretty quick and show you, and it was actually done by one of the audiology associations in Canada. Degree of hearing loss untreated is definitely tied to economic status. So if you have a hearing loss that's untreated, you could be in a position making less money financially because you're just not equipped to do the job properly, or you're not hearing, or you're not following instructions properly. So there is a stat there, and I can forward you that little PDF, and it doesn't just talk about financial, but social economic status, all of that. It's all tied to hearing. Absolutely.
Yeah, that would be great. And so I have the information, and I have the person's name here, so we can forward that on to the participant in today's session today. Excellent. So getting back to that engagement again, I'm just thinking, for people who love music, we know that music feeds the soul. And if you're not hearing, if you're a musician, or if you love listening to music, or, if you sing in a choir, those are the sorts of things that I'm thinking people may begin to step away from because they can't hear the notes, like they can't hear what they need to.
Yeah,
Yeah.
it doesn't sound like it used to. So, you know, we have people that come in here all the time that are musicians. I'm a DJ part-time, so I love music. Music is the language that we all understand. I can put on any song, doesn't matter what nationality or language you speak, people dance like it's universal. I love music. Um, we had a lady come in here, untreated hearing loss for about 15 years, used to play the piano 6 hours a day. She stopped playing it 20 years ago, or she would play it every now and then because it just sounded out of tune. We fit her with hearing aids. You know what she did? She went home and played the piano for 4.5 hours straight. She hasn't done that in 20 years. She called into the
Wow.
clinic, gave us a card and said, "You just gave me my life back." Now she can hear the music again and enjoy it. That's what I get to do. I love it. Like, it's a very rewarding job when you get to give that back. The only issue is people wait 7 to 10 years before they come in to see us. That's a long time. A lot, 7 to 10 years. That's like, geez, my daughter would be a teenager. And I missed out on all of that stuff. So, you know, having your hearing tested early and being proactive, I think that's what the whole goal of this presentation is get out. It's not going to cost you much or anything besides a bit of time. And if you have a hearing loss, there's options. So that's a great question. But music, you know, when I go see my mom may not engage in conversations anymore. But if I put on some Marvin Gaye or something that I know she loves, her toes start moving and she starts dancing.
She
Like,
starts swaying.
she starts swaying. And I'm sure you see that with dementia clients. Just
Definitely.
they might not be there, but you put the song on, wow, never forgot it, right?
Exactly. And I have a comment here too. Somebody said, my dad loves being able to pipe the TV music station into his hearing aids, and he sings all the time now. So he's actually
Absolutely.
piping that in. So, you know, that the ability to be able to hear those sounds again, which actually improves a person's quality of life and their confidence as well, right? You
Yeah,
know, and
and TV is like a big one, right? A lot of seniors like to watch TV in their shows, and that's the device that they have is like a Bluetooth enabled type device whereby, you know, the TV can be on mute, but that person can still hear it directly in their hearing aids. That technology is there. So let's take the distance away from the TV and give it to me here, corrected for my hearing loss. It doesn't sound better. It's out there. People just don't know about it.
yeah. And so what do some of those Bluetooth technology, like as far as hearing aids, what does that look like today?
Well, a lot of hearing aids are rechargeable now, so no batteries, right? So you don't need to worry about changing a battery. You put them on a charger. In the Bluetooth connectivity piece, it opens up a whole nother avenue for connectivity. So what it does, it allows you to, you know, I can connect to my phone. My phone could be over here or my iPad. And my iPad rings or I get a FaceTime call. Guess where I hear it? Right in my hearing aids.
Oh, wow.
Or the TV's on. I have a little box connected there. The TV streams right to my hearing aid. So if one person has a hearing loss in the house, the TV could be at the volume that the other person likes it, whereas the person with the hearing loss has their own control and it's right in their ears. So that's available. Also, just the ability to stream and connect like any music and stuff like that. You can plug into your computer. Lots of different options for the Bluetooth technology. It's been a game changer for hearing aids and hearing on the phone and stuff as well.
Excellent. So one last question here. Can one person's hearing aids be calibrated and used for someone else?
They can be. It depends on that person's hearing loss and the style of the hearing aid, right? So hearing aids that are custom made for someone that fit in their ear directly, typically they can't be recalibrated or reprogrammed, but ones that are behind the ear can be given the age of the device. So hearing aid manufacturers do not repair hearing aids older than 5 years old. So that's something that's just standard in the industry. But if it's a behind the ear, we can change the speaker. And if it matches or it has enough power to work with that other person's hearing loss, they can be, we'll say, reprogrammed. And we see people donate hearing aids all the time, and we donate them to the Lions Club or whatever, and they are fit on somebody else. So there's typically a fee associated with that reprogramming though, because you just can't take it off the shelf and stick it on another person, but it can be done. Good question.
Excellent. Well, that's great. Thank you. Thank you so much, Dekota. We had
Yeah.
a lot of questions today, a lot of really great questions, and I've learned some new information myself today too. So thank you for that. What we're actually going to do now is we are going to launch a poll. Marco's going to put one up there, and we'll just ask you to take a minute or two to respond to the poll as you see it up in front of you there.
Should I respond too?
Well, sure. Why? Well, I don't know. Why not? So as the poll is just coming through there, Dekota, I want to thank you again. Thanks for your time and sharing it with us this afternoon. I know we've all learned something. And thank you to everyone today for tuning in. And please feel free to send your comments or suggestions on future topics. Pop them into the chat, or you can give us a call on the 1-800 number there that's in front of you. And of course, the phone calls through our info line, it's confidential, intentional follow-up. So we'll have a staff member there that can answer that question for you. And just to remind folks today that the session was recorded and it will be available on our ASNS YouTube channel. Yes, the Alzheimer's Society has a YouTube channel, which is pretty cool. So you can watch it again, share it with your family members, or you can use it as a teaching tool as well. So thank you all again, and we hope you enjoy the rest of the afternoon.